So this is a 56-year-old lady with acute recurrent pancreatitis. No known etiology, but ever since her index CT 18 months ago, we've known she's had a 2-centimetre cystic lesion in the head of the pancreas. But we're not sure if that's inflammatory from 2 episodes of pancreatitis, or indeed whether it's a de novo pancreatic cyst driving the pancreatitis, which we sometimes see. So we haven't seen any stones in her gallbladder, which is noteworthy. There's no alcohol history here, so it makes the notion of there potentially being a structural etiology of the acute pancreatitis from the cyst. So here we're seeing the ampulla. So there's the bile duct and pancreatic duct coming together, and just trying to follow the pancreatic duct back, tortuous, and off it goes that way. So it's the main duct is quite far from the cyst. Actually, I say that it's very close to the cyst, because there's the cystic lesion there. It's very, very close, but we're not quite seeing it join, but that would certainly do for a side branch IPMN. So here's our cyst, which we've already measured. On the wall of this cyst here, we had a better view before, is a sort of asymmetrical, irregular nodule. So that could be mucus, it could be a little nodule with high risk for neoplasia on the wall of the cyst. Have we got contrast, guys? So it's an ideal one to use Sonoview for, because if this enhances, we'd be even more concerned about it. And it's also an excellent candidate for a 19-gauge needle, where we can take the fluid samples as well, but also see if we can get a Moray micro forceps down the 19-gauge onto this. But given that it's very small, in case we miss, I think the additive information of a enhancing nodule would be useful here. And that's enhancing. Look at that. That enhanced very early. It's now so that goes against that being a mucus. Okay, so that's my 19-gauge needle in the lesion, quite close to this nodule. So we're going to push in and pull back on the stilet. So there would have been some use biopsying the normal cyst wall here to determine cystic lesion caused by mucinous IPMN. It's slightly atypical for the unilocular cyst we would often see with a mucinous cystic neoplasm. But if this is a unilocular cyst elsewhere in the pancreas, biopsying just the wall of the cyst, particularly if unilocular, can be really useful to determine serous from mucinous. Right, here we go with the Moray forceps, going down my needle. I think I'm in quite a good position there endoscopically. Forceps, open. Actually, pull back and open. Open there. Back a bit more. Advance there. Close. Open there. Close tightly. I'm just going to hold the hand. Can you just pull that back? Just keep my needle in. Pull. Sharp pull. Good. And see what you've got there. So I think one question for the histopathologist when we send these in is this an neoplastic nodule? But if we happen to have hit cyst lining and missed the nodule, another question for them is this consistent with the lining of an IPMN? Presumably the answer to that will be yes. And of course the consistency of the fluid when we do aspirate it will be useful to confirm this is a mucinous lesion, as will be the CEA and fluid glucose. So that's 3 passes. I think one was more cyst wall than nodule. And we'll just take some of this fluid off now. And that is 6 mils of fluid, which is not a bad yield for something this size. So needle back. You put a couple of drops on a slide, and then one for biochem, and the rest for cyto.